Hey guys, welcome back to the episode today. And this is the Stretch Mobility Coaching Show. Today I'm going to be talking about mostly females, men you can listen to, but I want to talk about menopause. And I am going to be doing a series on menopause and as it relates to joint and muscle health, tightness, stiffness, and soreness. And today's episode, I want to specifically talk about why menopause raises your risk of a shoulder tear. Now, guys, this is going to be a case and a mechanism, and it's what the research supports and what it does not support. So thanks so much for joining me today. I do want to open the show today with letting you know that I finally finished and submitted my final book draft to my publisher. Now, the name of the book is Healthy Movement, and it's going to be the breakthrough science of how to move well for life. And this has been a 2-year project. And if any of you have spoken to me lately, you would be well aware of how long this has taken me to get this far with this book. And I am very excited that everything is turned in. The publisher has it all. So I want you to keep your eyes open for the big date that it will be ready to purchase. Guys, it covers the work I am going to lay out in this episode in a much greater detail. Now, today I'm presenting two things. I'm going to present a case from my own studio, and then I'm going to talk about the physiology that explains it. And I'm going to give you numbers we tracked on a client over time. And then I want to walk you through the published mechanism that accounts for what happened in this particular case. And the reason I'm going through it this way is so that you do not have this happen to you. Most of us don't learn until we've made a mistake. This is not a mistake I want you to make. So I want to make sure that you hear, what happened to someone else so that you don't make this same mistake. Because guys, this is not common knowledge, okay? One distinction before I start, because it governs everything in this episode, is, guys, I am not a physician. I am not here to diagnose disease, okay? So I assess movement and I track that movement, and I track that to see if it's healthy, in decline, or an accelerated decline. And that in decline and accelerated decline is the unhealthy movement that I am teaching you, and that's my platform. Now, that is a very different model. It is proactive. I look upstream to help you prevent common orthopedic conditions through testing and tracking. Now, other medical devices, they look at disease, they look at a diagnosis made after a tissue in the body has already failed. When we're looking at movement health and assessing movement, this measures capacity before it fails. And this case is about the upstream benefits of proactive care as it relates to health span, and right now in this stage of life, menopause or post-menopause. Now, I'm going to talk about a client that is a 53-year-old in menopause. She has been seen in our studio for low back prevention, and we began formally tracking her mobility health score just, I believe, in January, okay? And when she started, it was an 8, and within 30 days, we focused on work in her back, and she improved her mobility health score to 33. Now, when we do a mobility health score, we also do a movement age, and her movement age went from age 85. That's how healthy her movement was, because she was in accelerated decline, okay? So, and we're going to be talking about and breaking down all these numbers, but her movement age was 85, and after 30 days, it went down to 81. But what we're looking at here is she's a 53-year-old. Her movement age is an 85 that improved to 81 in 30 days. So even the smallest amount of work is going to change the numbers. But her numbers were measuring and showed measurable change for the low back. And during that same period, her thoracic kyphosis was increasing, and our testing showed it. And I made her aware of that overuse pattern in her shoulders. However, we continued really focusing our efforts on lumbar spine, pelvis, and lower body, just because that was closer to being symptomatic, and she didn't want any more symptoms in that area. She actually strained her shoulder when she was on a work trip, and then she selected to just follow the same programming she was on. And now, guys, she is scheduled for rotator cuff surgery. Okay. So from the time of the incident to, I think it was 4 months later, a rotator cuff tear in a 53-year-old. And guys, you need to know that in this age of life, in menopause and post-menopause, we have to be extra special, and we can't just go by the regular guidelines. In this case and point is me helping you to see the risk that you're under right now with the changes in your body due to where we are in our actual menopausal and postmenopausal state. Now, this episode is going to explain why a shoulder can fail while measured function is improving elsewhere in the same body. And this explanation is mechanical. And I'm going to go through the evidence here and go through the case for you. So let's dig right in. We're going to just start with background facts that are relevant to this case. Approximately 70% of women experience musculoskeletal systems through the menopause transition. And guys, when we're talking about that menopause transition, this is menopause to postmenopause, okay? Approximately 25% of those people are completely disabled by these things that happen during this time, okay? And these are the musculoskeletal symptoms. And guys, this is Vonda Wright's study in 2024. So if you don't follow Vonda Wright, then I would encourage you to follow her and learn more about this. Estrogen receptors are present in the joint capsule of your muscles, your tendons, your ligaments, and your bone. And estrogen withdrawal, that's what happens when we go into menopause and postmenopause, okay? Affects all of these tissues all at the same time. So it happens concurrently. Frozen shoulder is a shoulder condition most strongly associated with menopause transition that is in the literature, okay? But rates are lower in women that are using hormone therapy. So that's HRT, guys. In a large insurance database analysis of roughly I think it's 230,000 patients, women with estrogen deficiency had a 48% higher odds of undergoing rotator cuff repair. That was a research study that was done in 2022. Up to 20% of bone mass can be lost the first 5 to 7 years after menopause. So guys, I didn't put in this case the years of menopause, but I'm pretty sure I'm going to need to get those actual ages for you. But menopause is much younger than you think it is. So it's in the 50s. And then I think after 53, do not hold me to that. I haven't looked it up. I don't have it in front of me right now. But postmenopause is going to happen in your mid to early 50s. So 5 to 7 years after. So those of us that fall in that 55 to 60 or 55 to 62-year-old range after menopause, 20% of bone mass is lost in those years. Guys, 20% of bone loss, okay? So we're already getting into those ages, and bone loss is going to be relevant for osteopenia and osteoporosis and fractures, okay? Muscle deconditioning. That's when our muscles, we've lost a lot of muscle and we are no longer, our muscles are not in a healthy state, okay? They're not functioning the way that they used to function when we were younger. And muscle deconditioning produces no pain, guys. You're not going to feel pain while this deconditioning is progressing. It is detectable by assessment before it's detectable by a symptom. Okay. And a 13-year prospective cohort of more than 3,000 adults found whole body joint mobility was associated with substantially higher mortality risk. And guys, it's higher for women than men. A joint mobility assessment is not part of a current routine for perimenopause or postmenopause care guidelines in our healthcare system. And then pain is a late signal in this process, not an early one. So I just want you to understand those statistics and why we are not catching the things like the rotator cuff tears and why surgery is needed and why we're not getting frozen shoulder. So here's the case. I'm presenting this as a case, okay? I'm going to review the data first and then I'm going to interpret the data after that. So this lady that came into the facility, we didn't test mobility health score when she started on her program. She was on a monthly program. Then she came in one day and said, oh, I think I'm getting symptoms of sciatica. I think it's going to come back and I'm worried about it. So she jumped on a program. I think she did 2 of our joint mobility jumpstart programs, and then she got back on a maintenance. Okay. So those programs were just really aggressive where we saw her 2 times a week. So we did not track her mobility health score until after those 2 jumpstarts and after a few months of her coming in weekly for stretch mobility coaching sessions. Okay. And on our scale, when we tested her mobility health score and it was an 8, that is deep accelerated decline. That is your at-risk phase, meaning that you are going to become symptomatic soon, or you're at risk to tear tendons, to tear the labrum. Your muscles, tendons, ligaments are at risk with this health score, okay? So the health scores 80 and above are healthy, and you can manage that through strength and conditioning programs. 79 to 60 is where you need to incorporate stretch mobility coaching so that you can improve the health because you're already in decline. And then 59 and below represents deep accelerated decline. This is your at risk. You have lost greater than 50% of your joint mobility in multiple joints in the body. So your movement is at risk, okay? You're at risk of losing it, meaning you're at risk of pain showing up or something tearing, and it will happen. So that is our testing. Now, her initial movement age was 85 and chronological age was 53. That was a 32-year gap between measured movement function and her age. Now, her prior care, she did 6 months of work directed mostly on the low back with reported improvements in her joints and muscles in that area. After 30 days of focused joint and muscle work, her mobility health score in the lower body area rose from an 8 to a 33. So she was still at risk in that area. Her movement age moved from an 85 to an 81 over that same period. Her thoracic kyphosis, that is when she has forward posture and we have that hump that's forming, noted that it was increasing. She was getting more kyphotic during this time. I noted that. I did tell her about that. In our 1 time a week session programming, we're addressing it within our session. And the assessment showed an overuse pattern in the shoulders during this time. She was aware that her shoulders were not in a healthy state. She was aware that we were working on it. And this is a record of a measured movement over time. That, guys, this isn't a tissue diagnosis because I can't do this. And I want you to understand that what we're looking at is upstream. How do we prevent when we're in menopause and postmenopause? So this lady did not have any pain. Let's interpret these numbers a little bit, okay? So the mobility health score rose because the stretch mobility coaching work was directed at her low back, her spine. And that score improves where most of the work is being applied. And that is expected and it's consistent with the data. A regional improvement is not a whole body status improvement. So her shoulder was not the focus of the coaching work. We had noticed it. We were throwing in a couple of things, but the assessment had already identified an overuse pattern in the shoulders and an increasing thoracic kyphosis around them. And these 2 findings were not independent of each other because the thoracic spine is the foundation the shoulder blade moves on. And an increasing kyphosis, more forward posture, it changes how the shoulder blade sits and loads on the shoulder. The mechanism is explained a little bit lower. Now, in the menopausal body, the underlying decline is systemic, okay? Because the hormonal change acts on every joint capsule and muscle. It's just systemic. It's all over the body. Improvement in one region, her lower body, and progression in another can occur at the same time. And in this case, that is what was happening. So here's the key point. When you're working on a certain area where work is applied, it doesn't indicate status where work is not applied. Okay, so regional improvement and regional decline are going to coexist when the underlying process is all over the body. And this is why whole body assessment is required rather than symptom directed assessment. Now let's talk about the mechanical event. In this case, the client's shoulder strain occurred during routine overhead lift of luggage while on a work trip. And this client felt something weird. And when she arrived for her normal visit, and I don't know how many days after that she arrived, I don't know if it was a week later, I don't recall that, but she said her shoulder was a little stiff and sore on that side. A lift of that magnitude does not exceed the capacity of a conditioned shoulder. So someone who is not menopausal or postmenopausal, they would have felt that overhead lift as a strain and not exceed the capacity to heal. But because this lady is in menopause, it exceeded the capacity of her shoulder, which is deconditioned. So her muscles are deconditioned and her joints are in decline. And a person in menopause that has noted kyphosis, so if you are in menopause or postmenopause and you are noticing that hump, and your joints are tight in the shoulder system, that is considered to be in a deconditioned state. And it was also indicated in her mobility health score of 8. Okay. So following the strain, this client elected to wait for spontaneous resolution and did not change her frequency of care. Currently, to go over that, she was strength training 20 minutes twice a week. She was seeing us once a week, primarily focusing on the lower body, but we were jumping up to the upper body and giving her a few things on that. This is the standard response of most people because most of us think that based on the healthcare model, that's all we need. Okay. And we really don't have standards, well-established standards for this. So I am still digging into the research on this and I'm pretty amazed at what this is showing. So you'll have to tune in to learn as I learn. But this is the standard response that most of us make. And it's based on a model of healing that does not apply in this physiological context. Okay. Because she's menopausal. It's different what happened to her mechanically than in someone who was already in a conditioned state. So in a pre-menopausal body, delayed presentation is often reasonable because endogenous repair signaling remains intact and minor strains are going to just resolve themselves. In a menopausal body, that repair signaling is reduced. It's delayed and it does not produce resolution. It produces continued progression of an already advanced process. And in this case, the interval of waiting was associated with the following sequence. She had continued inflammatory load in tissue with reduced anti-inflammatory regulation. She had continued joint capsule restriction with nothing applied to address it. She had continued inhibition of the deep stabilizers and continued compensation by larger muscles. She had progressive loss of joint centration and impingement of the tendon beneath the acromion process. And guys, when we're looking at the shoulder, I did a show on this, so go back to it. This bone is supposed to be centered in, this would be the back, your back side. This would be your front side. This bone here comes across here. This is the head of the humerus, okay? So because of losing centration, that just means she's up a little bit right here. So the tendons come up and over this. And when it's up a little bit, when she goes to roll up, the bone is going to hit here, which is going to pinch on those rotator cuff muscles. It's up this way and not centered. So the body compensates with the larger muscles. This does not move and drop down and it's not centered like it's supposed to. And back here, if you wait too long in this menopausal state, in postmenopausal state, you're going to start growing bone here, which is arthritis, which is going to push that head of that humerus up higher and sit higher, which is going to put more strain on your rotator cuff, okay? Bone spurring formation is a secondary response to the loss of the joint position, okay? The loss of the head of the humerus losing its centration. Now, imaging is typically ordered after pain became a signal, okay? And for this lady, when she had imaging, it showed bone spur formation already present. And the rotator cuff tore approximately 1 month after the pain onset. The sequence that I'm talking about here is consistent with progressive deconditioning of the muscles, also decline of the joint, and the mechanical failure, which was her lifting up that suitcase, that luggage event. It actually precipitated, and then the waiting interval just caused everything to progressively build more bone. She had not stopped her exercising. I think she stopped. Oh, you know what? If I remember correctly, she also had an incident when she was doing her 20-minute workouts that she was doing an overhead movement and she felt a pinch. So she stopped doing overhead movement. So during this time, all of that was consistent with what precipitated, and that waiting interval actually caused more formation of bone spurs. And then over time, that inflammation continued, the joint capsule continued to be restricted, and then restriction then became more prevalent in the other joints of her shoulder system, okay? So let's talk about deconditioning. We're talking about the muscle here when I'm talking about deconditioning. So when I said a 30 or 40-year-old that they are conditioned, that their muscles are in good condition, someone in menopause and postmenopause, their muscles are in a deconditioned state, okay? And this is the physiology that accounts for this particular case. The joint was in decline, okay? We talked about that. Now, this is the muscle deconditioning. This is all of the muscles that surround and support the joint, and then all of the muscles that allow the joint. And when I'm talking about the joint, I'm talking about the head of the humerus here, but I'm also talking about the scapula, okay? These two. So muscle deconditioning is not a single process. It is a cascade, and it has multiple entry points with a shared set of mechanisms. And the entry points are well described in the literature. The ones I'm going to go over with deconditioning today are the ones that I have seen and I have been versed on. Disuse is one of them, and this is reduced movement through full range, reduces the capacity of the muscles around a joint. Aging. At this point, you're going to lose type 2 muscle fibers at this age of the menopause and postmenopause. We're going to see a decline in satellite cell number and function, reduced anabolic sensitivity, and decline in hormones. And this is including estrogen. Now, overuse occurs when these deep stabilizers are inhibited and the larger muscles assume movement, and they're not meant to sustain this, okay? So they start to break down. So in her case, we had already noted that her shoulders were being overused and they were at risk, and that was not going to stop until we got thoracic mobility gained back. Now, some other categories here of this deconditioning mechanism. There are pathological. This is disease, okay? It can be post-diagnosis. It can also be post-diagnosis from an injury, or it can also be metabolic, okay? It can be neurogenic, mechanical from an injury, or metabolic from joint restriction. This could be from spinal compression. In this case, we definitely have a lot of joint restrictions in the shoulder. This is going to also, it can be metabolic diabetes, autoimmune disease. You're going to see delayed healing, reduced repair signaling, and it means the tissue, it just does not recover like it did in a muscle that is in a conditioned state. And beneath all of these entry points, aging, disuse, overuse, the pathological, neurogenic, and metabolic and nutritional, those contributions, all of these occur, okay? You've got decreased neural drive to the muscle. You've got decreased loading, decreased nutrient availability. You've got increased inflammatory cytokines. increased stress hormones, increased oxidative and metabolic stress. These mechanisms all operate together and they account for the loss of capacity regardless of what category of deconditioning she's falling into. And these mechanisms correspond directly to the 5 drivers of healthy movement. This is the framework that I talk about that is required for your movement to be healthy. And it's the same framework that the deconditioning mechanism is organized into. Okay. All of those things have to be addressed. You have to look in a person who is in a deconditioned state. You have to look at all of those things. You can't pick and choose 1 or 2 of them. Okay. Let's kind of dig into inflammation for just a second. I know that's sort of a buzzword that all of you guys are listening to, but inflammation is the common factor across all 5 drivers of movement health. Okay. Estrogen withdrawal during menopause increases an inflammatory signaling. The inflammation basically feeds all of the mechanisms above. It's going to affect your joint. It's going to affect your muscle. It's going to cause cellular stress, increase oxidative stress. Your cellular health is going to be impacted. Your joint health is going to be impacted. Your muscle health is going to be impacted. You're going to have decreased nutrients and reduced anabolic response. And then your nervous system is going to be impacted with this because of the increased stress and the lack of those hormones. And then of course, metabolic stress placed on top of that. Now, this is the physiological basis for the position that addressing only part of the cascade does not stop it. The cascade, which I call the silent shutdown cycle, it operates on 5 mechanisms concurrently. And if you address just one area, then the other area is not going to get the benefits. And let's talk about the evidence, okay? If you address the low back, which we did in this client, and that was our main concern because she was worried about symptoms in that area. And again, we worked for a few minutes on the thoracic area. We noted it as a problem and she didn't feel it was a problem and she didn't understand it. And that's again why I'm doing this podcast today, this episode. I want you to understand that she was already in a deconditioned state and the deconditioning mechanisms operate concurrently. In this case, the coaching work was working in the low back region, okay, because she was doing many of those drivers. I don't know that she was getting her protein. She was really struggling with getting protein. She was getting red light. So she was addressing 1 time a week red light for the cells. I don't know that she was really building skeletal muscle. She was doing a strengthening program. She was following a 20-minute twice a week program. And guys, listen up to this. After this episode, I'm going to dig deeper into what amount of strength training you need to do when you're in a deconditioning state. And it's a lot more than you think it is to make changes in kyphosis and, make sure that we are saving our shoulders. But for this actual episode, I just want to let you know that when we're working on one area of the body and we're not addressing an area that is in decline and you're in a deconditioned state, and on top of that, you're menopausal or postmenopausal, that means, it's just a matter of time. I don't want to say it to cause fear because this is not fear I'm looking for. To me, I want you to understand your body. I want you to listen to your body. And I want you to also understand that when you were 30 and things got better, and now that you're in menopause, things don't seem to get better, your body is in a deconditioned state. Unless you're following the 5 drivers and your strength training, you're doing appropriate strength training and all of the things. And if you don't know if you're doing those, then we need to jump on a call because I want you to better understand what you need to do to protect yourself during this time period. So let's talk about why menopause itself accelerates the cascade of decline. The cascade that I described above occurs during, our mid to late 40s to 50s, depending on if you're in menopause or postmenopause. The menopause transition actually accelerates this cascade. And the cascade I'm talking about is the decline in the joint and the deconditioning in the muscle. This is general physiology established in the literature, and it's not specific to any one individual. And the relevant framework was named in 2024 by Dr. Vonda Wright and her colleagues in the Journal of Climacteric as the Musculoskeletal Syndrome of Menopause. And it describes the collective musculoskeletal effects of estrogen decline. Now, the function of estrogen in the musculoskeletal system, it acts across the musculoskeletal system through receptors present in the joint capsule, the muscle, the tendon, the ligaments, and the bone. And it is documented. Its functions include maintain joint capsule elasticity, support of synovial fluid production, support of collagen quality, regulation of inflammation, and support of the satellite cells involved in muscle repair. Now, the effects of estrogen withdrawal, and guys, when we're in menopause, we're losing estrogen, okay? Actually, we're losing it, I think, perimenopause and a little bit, and I don't have these numbers for you, through menopause, and then because of during menopause, that next 5 to 7 years, okay? With the decline in ovarian estrogen production at menopause, the effects are concurrent across all of these tissues. Your joint capsules thicken and they lose the elasticity. So if you guys feel like you're a little bit stiffer, you are. And guys, if you're just going out and you're taking hormones and you don't feel as stiff, that doesn't mean that your joints are not unhealthy. So I want you to understand the difference so that you have all the information you need, because I don't want you to end up in surgery when you could have avoided it. Synovial fluid production actually decreases during this time. Collagen quality declines and tendons become more fragile, okay? Inflammatory signaling increases in the tissue and you have a reduced regulatory protection. Muscle repair capacity decreases as your satellite cells support this decline. Guys, you've heard of sarcopenia. It actually accelerates, and anabolic response to training also decreases during this time. You need to go into menopause and postmenopause strong. And most people can't get strong because underlying their movement system is not in a healthy state. Now, the last decline in ovarian estrogen production, that it affects bone mineral density, and that means your bone mass decreases, okay? And because estrogen receptors are distributed across all of these tissues, the effect is systemic rather than localized in one area. And this is the physiological basis for the observation in the case that decline can progress in one area of the body while your measuring function improves in another part of the body when you're working on that. And the hormonal change does not act regionally, okay? It acts everywhere at once, okay? So I want to dig into the thoracic spine here and the shoulder, because this is the mechanism that connects the two findings in this case. The increasing thoracic kyphosis of this client and the shoulder overuse pattern, they weren't two different events. One produced the other. The thoracic spine is the foundation of the shoulder blade. That's what your shoulder blade moves on. And during any overhead reach, when you're reaching up, the shoulder blade has to upwardly tilt, and then it has to rotate outwardly. And it can only do that if the thoracic spine is in an extended position. So here, and you extend. The problem is when we've got this biomechanical change, okay, now your thoracic is in a kyphotic position, then this doesn't glide the way that it's supposed to. So this joint is affected, and then this joint again is affected by not being centered, okay? So the kyphosis affects how the shoulder works, and these two systems work together, okay? Kyphosis in the population of someone who is in menopause or post-menopause is multifactorial. You have to look at many different things. The recognized drivers are degenerative changes. Weakness of the spinal extensor muscles occur, and most age-related kyphosis, you're looking at problems in the disc and problems in the muscles, and it's not explained by bone loss alone. Estrogen loss is just one contributor in that picture, and it accelerates the bone loss and the muscle loss that are two of the recognized drivers, okay? It is a contribution to a multifactorial process. This is not a one-to-one cause. The kyphosis is one component, the shoulder is another component, but they both work together. And what matters for this case doesn't depend on resolving the cause of the kyphosis. The kyphosis was measured as increasing. As a kyphosis increases, the shoulder blade is forced into a forward tilted position. And because the blade has to follow the contour of the rib cage, that forward tilted blade reduces the space of the rotator cuff. Okay, so you're up here, and also the head of the humerus is not centered. So when the rotator cuff passes through this, when you do any overhead stuff, you're going to compromise that and you're going to be more at risk for tear in your rotator cuff muscles, because that space that they're talking about is here. Okay. It's due to the humeral head losing its centration as well as the thoracic spine. And now that scapula can't glide like it's supposed to. Okay. So the whole system is off here. And then the rotator cuff has to work within a compromised position and the larger muscles take over the load. And now this is when you're going to be building bone spurs. And that's what an overuse pattern in the shoulder is. And this is what places menopausal and post-menopausal clients at increased risk for rotator cuff tears. Okay. I want you guys to understand that what we have to do when we're in menopause and post-menopause is we have to protect these rotator cuff muscles. And these rotator cuff muscles, it's not about just doing internal rotation and external rotation exercises. Guys, you have to go and make changes in the thoracic spine to gain mobility in that, because that is going to place the stress on the shoulder at one part. And then the other stress is the loss of centration and then the bone spurring back here. All of that is already got you all set up for tearing your rotator cuff. So during this time, if you're saying, hey, I'm just going to go to the gym and I'm just going to keep these muscles strong, that is great. But I'm going to tell you right now, unless you stop that cycle, that cascade silent shutdown that is happening, you're not going to feel that the bone is growing and you've got bone spurring. You're not going to know that your tendons are actually being frayed in here. You're going to see that you're not standing up as well. You're going to probably feel tightness in your shoulder. But above that, those symptoms have already been compounding. So you are already at an at risk. And this lady was already at risk when she walked in my door. And so as a female, we need to understand that we can't just do strengthening exercises on our rotator cuff and expect to make improvements that are going to take the risk of shoulder rotator cuff tear away. Okay. We're already seeing the effects of estrogen in menopause and postmenopause as declining. We already know that silent shutdown has happened years before. We already know that in menopause, things do not repair like they did when we were in our 30s. And just like this lady, she thought, hey, I'm strengthening 2 times a week, 20 minutes each time. I am doing joint mobility work 1 time a week. So that should be enough for me. And just because I know I have kyphosis and I know my shoulder's at risk, she didn't understand that the urgency to reverse those things should have been greater to prevent that rotator cuff tear. Because guys, once you get to the doctor and the doctor goes, you have bone spurs, and then he's going to send you to therapy. Therapy is going to focus just on the area of dysfunction. You're not going to fix the root cause of the problem. And so without that, and I don't know if she stopped working out during that time too, you just don't do that. You just can't do that. So if you're going in for physical therapy, go in for physical therapy. Don't stop your workouts. And if your therapist says stop your workouts, whew, maybe you need to modify your workouts. You need to understand how to modify them, but stopping them is not what you need to do. And then at this point, you really do need to make sure you're addressing joint mobility in the thoracic spine, cervical spine, shoulder, and the whole body, because women with estrogen deficiency have a 48% higher odds of rotator cuff repair. That means, guys, you're gonna tear. You're not an excluded case or a special case. This is in the literature. And it's not a proof of direct causation, okay? It's just saying that, hey, if we're going to be looking upstream, and we definitely don't want to tear our rotator cuffs during this time of life, we need to make sure that we get an assessment, know our mobility health score, know what information we need to know, because guys, it's between ages mid-40s to 60s. And I'm not even talking about when you're in your 70s. I'm just talking mid-40s to 60s. There's a silent cascade that's happening, and I call it the silent shutdown cycle. And it is systemic. It is accelerated in menopause, and it is not detectable by a symptom. And a symptom is pain, tightness, stiffness, soreness. It is not detectable by a symptom until it is way far advanced. And a process with those properties can't be managed by symptom-directed care. You can't get a massage. You can't stretch it away. It requires an assessment that does not depend on symptoms, okay? Now let's talk about symptom-directed care. I call that reactive care. And care directed by symptoms address the region that reports the symptom. And for this case, this client had low back tightness and hip tightness. The shoulder didn't report any symptoms in the same period that the low back did. So just because we identified that her thoracic kyphosis was increasing and that she had, increased risk of a tear in her shoulders, because the focus of our care was still on the low back, she did not have what she needed to set her shoulder up for success. So time constraints from a 1 time a week session didn't allow for us to provide equivalent care to the upper body. And this silent deconditioning in the muscles, the silent decline of the joints, and the added menopause, this client needed to increase frequency to work on all of these things. And guys, I know that's a lot. We look at this and go, so the standard that they're telling us of doing 15 minutes of strength training 3 times a week is enough. Guys, it's not enough. And there is way more that you need to know. You need to know what your whole body assessment, your test is. And a mobility health assessment evaluates every joint and the activation of the muscles around that joint. And it does that independently, whether your region is symptomatic or not. And it's going to produce a mobility health score and a movement age. These are going to provide a measurement of the cascade before it reaches the symptomatic stage. And the symptomatic stage is pain, stiffness, soreness, and tightness, okay? Now, this is the interval in which the process can still be changed. And you don't have to do that much. You just have to follow what recommended frequency, and you need to know what you need to know. And at this point, I think we've been conditioned to think that, well, my mom didn't have a tear, so probably the risk of my tear is lower. And guys, this is not a genetic thing. You can't look at genetics. You can't look at, hey, when I had my last shoulder pain at age 30, it went away. You can't look at those time factors because at that time, your muscles were in a conditioned state, and probably her mobility health score was a lot better at that time too. But after the symptomatic stage, the available options narrow toward a surgical pathway. And that is what is described in this case. And the key point here is, guys, if you are getting symptom-directed care, then you can't expect that other part of your body is not going to continue progressing in that silent systemic deconditioning, because that is what's happening. So even with this lady, we were working on her low back, and that was her focus and that was her concern because she wanted to make sure she didn't have those symptoms. Stopping doing stretch mobility coaching while she focused on her shoulder now puts her low back at risk. So, and we see this all the time, okay? She is now going to be at risk for back surgeries, hip surgeries, knee surgeries. Her start of this is a shoulder surgery. And I just want you to see that we have to catch this. We have to look upstream of this. The mobility health score is an assessment. It identifies where the cascade is active right now. The coaching work then follows a defined sequence, and the frequency is determined by the degree of deficit and the physiological context. Now, the sequence in general is we need to assess the whole body, and we need to measure the joints. We need to see if they are in decline or at risk, and we need to give you a mobility health score and a movement age. That in itself is going to tell you a lot. Then we need to not only do that, because if you get that score and you go and work out, you're not going to see improvements in that score because we've been tracking this data. What you need to do after you get that assessment is you need to restore capsule mobility. You need to make sure that the joints that are restricted are addressed first, because capsule restriction is the input that reduces the neural drive of the stabilizers. That means your muscles that support that joint are shutting down. The muscles that move that joint are holding, and that's where you're getting your tightness. So we need to restore the mobility in that joint and restore the health of the capsule, take it out of the decline. We need to reactivate the stabilizers and keep them activated. And we need to make sure that the larger muscles can move like they're supposed to. Then we need to do loaded strength work, and it's applied after the foundation is restored, okay? So that load reinforces correct rather than in a compensatory pattern. And then we need to maintain this through ongoing work. And this continues at a frequency set by what your mobility health score tells us. That is the only way those of us that are in menopause and postmenopause, because of this estrogen decline, and even if you're on HRT, guys, okay? I'm not saying that those of you that are on HRT are not still, you may not feel symptoms, okay? It is going to help keep those joints gliding better because of the collagen, because of the other things. However, it doesn't mean you're not in silent shutdown. And guys, there's not a person on this earth that isn't in a shutdown, because we're all aging. Okay, so over 40, you need to make sure you have your mobility health score, and it becomes even more important during that time. Now, frequency as far as strength training is concerned, as far as stretch mobility coaching, as far as any other treatment, needs to be adapted, and it needs to be adapted based on the mobility health score. This is the tool to help us know what we can and can't do. This gives us the confidence to know what is going on in our body to avoid the downstream effects of rotator cuff tears, bone spurring, surgeries, chronic disease, metabolic dysfunctions, all of that stuff. We need to look at frequency to scale based on the measured deficit, and a joint deep in the cascade requires more frequent input than one that is not so deconditioned, okay? And a menopausal body requires a higher frequency than a premenopausal body to achieve the same change, because the endogenous repair signaling is reduced for those of us that are in menopause and postmenopause. Now, just because you have an incident doesn't mean that you stop doing the work, because if you stop doing the work, then other areas of the body that are in silent decline are just going to progress. Guys, that is why we see one surgery, then another surgery, then another surgery, then another surgery, okay? In menopause, you do not get the spontaneous resolution that you got in your 30s, because your muscles are not conditioned and your joints are in decline. So you need to maintain a frequency that is established by reassessment. Know your numbers, okay? Don't just guess at this, because guessing is going to keep you in that loop, in a shutdown, and then you're going to be that person laying on that bed going, what happened? How did I get here? So in this case that I presented, the frequency was not increased after the incident, and it was not matched to the degree of deficit that was present in her thoracic spine, her shoulders, and the coaching work didn't match the physiological context. So the outcome is consistent with the gap here. So the shoulder went through a shutdown that was accelerated by menopause, and then the mechanical injury occurred. The gap to improve the shoulder function would be increasing frequency based on the research and working on every joint in the body each session. Based on the research, I'm finding that menopausal and postmenopausal clients require 3 times a week for 1-hour sessions for a longer frequency. And guys, that research that I'm finding is a year to 2 years, okay? You have to ensure that you have changes in that thoracic spine. You have to get that extension back in that thoracic spine. And then you need to make sure that the shoulders during this time are staying strong. And I'm talking about every single deep stabilizer needs to be reconditioned. So does the larger muscles. And that is what is going to help us decrease and reduce our injury risk for rotator cuff tears. To summarize this case, the mechanism was the overhead lifting of the suitcase. And as I'm remembering, she also did overhead strengthening. She was already in menopause and she was showing signs of progressive joint and muscle loss in the entire body. The deconditioning cascade operates through a defined set of mechanisms that correspond with the 5 drivers. Estrogen withdrawal accelerates all of them concurrently, and the process is silent until it's advanced. And for this case, the frequency of coaching did not match what the desired outcome required to reduce the risk of a shoulder tear. So the practical conclusion is pretty specific here. A silent systemic process is not detectable by symptoms and is therefore not manageable by symptom-directed care. Guys, it can only be prevented by taking a test, understanding the health of your joints, understanding how deconditioned your muscles are. And the only way you're going to be able to do that is through getting your mobility health score. The programming after that to reduce the risk of a tear in this population, and we're talking about menopausal and postmenopausal, should be based on the research that supports change in kyphosis. So you've got to decrease the kyphosis, and you've got to increase the extension in the thoracic spine. You have to improve shoulder mobility, joint health, and muscle health in the spine, in the shoulder, and all of the shoulder joints. This population can become symptomatic with one episode. This case shows that. And guys, that seems small. It seems very small. Based on a lack of estrogen and poor healing and poor repair in this population, testing and research-based programming would be recommended to reduce the risk of shoulder, rotator cuff tears, and the progression of this kyphosis. Now, the mobility health assessment is a measurement, is performed in our studio in Beckett Ridge, and it produces a mobility health score and a movement age for every joint independent of a symptom. We have a free self-test on our website right now, and you can go to www.thestretchmobilitycoach.com, and you're going to see a tab at the top of the website that is free self-test. It is a screening tool, guys. It is not a substitute for the assessment that I do inside the studio here, but it does give you a little more ability in 5 minutes to test your overall movement health. I'll put a link to the free self-test in the show notes below so that you can head over and take that test. Guys, if you are not menopausal or postmenopausal, take the test. If you are menopausal or postmenopausal, take the test. Right now, you just need to know what your movement health score is. And that test is an indicator. And guys, go back, take the test again and again and again and again. It is free. It is a tool that you can use because, one day you may wake up and go, oh my gosh, I'm not able to do that test, but yesterday I was able to do it. That's going to give you some urgency. I want you to not forget to keep a lookout for my upcoming book, Healthy Movement. It is going to be packed with more information on the Silent Shutdown Cycle, and it's also going to provide you with more free information. I have a lot of stuff in the book that you guys can use as resources. Guys, it is so important that you know your mobility health score. It is so important that you control this decline because it is aggressive and you don't want to be one of these statistics. Follow us on social media. Make sure that you're following, you're going back to that free self-test as much as possible. And guys, if you're in the Beckett Ridge area or somewhere nearby, come in and get your mobility health score. If you're not in this area, let's jump on a Zoom call and let's do as much testing as we can do. And I can make sure I give you information. Even though there's no stretch mobility coach near you, we can kind of band-aid together something that you can do so that you're at least addressing the 5 drivers as best you can address them. So hope you guys found this information helpful. I appreciate you joining me today. Guys, if you are menopausal and postmenopausal, that's all of us ladies right now. And guys, you're not excluded. I'm going to do some more testing for you guys, but stay tuned, guys. I'm going to give you some more information on this topic of menopause and postmenopause because I feel like it's important for you to understand what is going on in your body, why your body is not healing like it did in your 30s. There is a reason, and what you can do about it so that you can move like you did 10 years ago. Thanks for joining me on the show today, and I will see you next week. Have a great day.